Good afternoon, and thank you very much to Marion and the MBRRACE team for inviting us to talk on lessons on prevention and treatment of hypertensive disorders. We're taking a slightly different approach this year because, as ever, I'm delighted to say there are not a lot of deaths from hypertensive disease. So this year we've got a collaboration with HSIB, and we're looking at both hypertensive-related maternal deaths and learning from the HSIB review of babies who died or had a severe brain injury whose mother had hypertensive disorders. And we'll cover that later in this presentation. So these are the recommendations, and I'm starting with the recommendations as well as ending with them because often that's what people really want to know. And I'll point out the first recommendation, which is related to aspirin, which is really very similar to previous recommendations, and there's an emphasis on the need to have ease of access to aspirin for our women. We will go through the recommendations as we go through the presentation and then give you them again at the end. And this is the other slide that everyone's always waiting for, which is the numbers. And the numbers are really a little bit disappointing. Back in 2012, 2014, we only had 2 deaths to present from pregnancy hypertension-related disorders, which was a really very low death rate of 0.09 per 100,000 maternities, which is approximately 1 in a million. In this triennium, there are 8 deaths to report, which is approximately a 4-fold increase, though it is not statistically different. You can see here the cause of death spread across acute fatty liver, HELLP syndrome, eclamptic seizures, and pulmonary edema. And of interest is that pandemic affected the care of 3 of these women. Can I remind you yet again that we're only dealing with 2018, 19, and 20. So the pandemic was really only just getting going for the latter part of this triennium. Here in more detail are the causes of death for these 8 women. And you can see that deaths from intracranial hemorrhages have stayed low over the last 3 years compared with what they were like back in 1997. Sadly, seizures are still a cause of death, as is HELLP syndrome and acute fatty liver. If we look at maternal mortality rates, this is rates per 100,000 maternities and takes into account the fact that these eras are slightly different. And you can see that there has been a significant, or what looks like a significant reduction in deaths compared with 2000 to 2002. But it has really been very stable, sadly, since 2006, unless we feel as though it really went down and has come up again. But I would read that as being effectively stable. So the improvements that we made have probably been maintained, but we've not continued to make improvements. As ever, we've looked at the quality of care, and it's really very sad to say that in this particular category, 6 out of 8 of the deaths, improvements to the care may have made a difference to the outcome. That is 75% of the deaths we may have changed if we had different care. That's quite a sad thing to say. Comorbidities are really very common in the women who died from hypertensive disorders. 2 of the women, that's 25%, were significantly overweight with BMIs of over 40. There were women with diabetes and hypertension. There were women with complex medical, psychiatric, and social needs. And I've actually included in my vignettes some of the women who actually are in the cardiac chapter. They died of cardiac hypertensive disease. So they didn't die of hypertensive disease per se, they had a cardiac death, which is why they're in that chapter, but they actually did have hypertension as the underlying cause. So to move on to the vignettes, which are always interesting when we're looking at what we can do differently. This is a young woman with a really very large BMI of over 50. She'd had previous pregnancy loss, so she was obviously considering getting pregnant. She was known to have asthma and sleep apnea, and she was known to have hypertension. But there was nothing in her notes to suggest that anyone had talked to her about the chances of getting pregnancy and potential complications in pregnancy. So she had no contraceptive advice and no health optimization. She had poorly controlled hypertension, and she collapsed at home near term. They did try and resuscitate her, but sadly, she died without being able to be brought back. There was another lady with known hypertension who went overseas for her IVF, and there was no evidence of pre-pregnancy counselling. Now, you may say that this is out with our control, but I suspect her GP knew that she was considering getting pregnant, and I suspect her GP may even have known that she was considering going overseas for IVF treatment, as it was either cheaper or something that she'd be able to access. So the lack of pre-pregnancy counselling, again, was something that could have been considered at the GP surgery when giving her her next prescription of antihypertensives. If we look at the characteristics of the women, can I remind you there were only 8 of them, so actually these numbers don't mean very much in themselves. But I think of note is the fact that the women were older than the average woman having a baby, so 63% were over 30. 50% of the women were from non-white backgrounds, and 50% of them were in the upper 4th and 5th quintile, or should I say lowest 4th and 5th quintile of socioeconomic deprivation, whereas it should of course only be 40% in 2 quintiles. So as ever, these are the poorer members of our society. These are overweight women, and sadly, it's also women from minorities. So to describe a woman who's actually in the cardiac chapter, if you're reading through the chapters, and may have been mentioned in this morning's talk on cardiac disease, so I apologise for that. This is a woman who is a grand multip, obese, hypertensive, and in her late 40s. So it describes a lot of women who come through our hypertension clinics. She had both medical comorbidities and mental health comorbidities. She also smoked, and she was actually well looked after through her pregnancy. She was seen in the multidisciplinary team. She received aspirin early in her pregnancy and appropriate thromboprophylaxis. Sadly, she developed preeclampsia, but that was okay. She was induced and had a live late preterm birth. What's really sad is that she died 3 months postpartum from an acute myocardial infarction. This myocardial infarction was not picked up at the time, and she died a few weeks after the infarction. So this is a woman who maybe we could have picked up prior to pregnancy to discuss not getting pregnant, and then she may not have had an ongoing complication. Sadly, I have aspirin to talk about yet again. We all know that aspirin reduces the risk of preeclampsia, and many of us will understand the difficulties in actually getting prescriptions to our women. This is a woman who booked for consultant care. She was recommended by her midwife to start on aspirin, didn't get any. She saw her consultant in the 2nd trimester, and he gave her a letter saying, go and get some aspirin from your GP. The GP did not receive the letter for a further 3 weeks, so she did not start on aspirin until well into the 2nd trimester. Would earlier aspirin have stopped her from dying? Who knows? But she did develop severe preeclampsia and sadly developed pulmonary edema, which was proved fatal. We have previously asked for changes to be made to the prescription dispensing of aspirin, and there is now a patient group directive which should enhance the ability for aspirin to be dispensed by pharmacies without it having to be prescribed by a doctor. But this continues to be a problem and is something that all our local areas need to look at to make sure that we are able to get aspirin easily to our women. Access to records is also really important, because another important issue with the lady in the previous vignette was that she had electronic records, but these weren't records that the GP was able to see. Unshared electronic records increase the risk of poor information sharing. And this is something that we see as we change from paper to electronic and ensure that our GP colleagues and our women have actually got access to the GP records. So this is something that our hospitals, our trusts, our local areas need to make sure we're working on in tandem. We all know the paradox of trying to engage with the women at highest risk. And it's really important that we actually make real efforts with this. There are two separate women on this vignette, and I'm going to read the second one in detail rather than the first one. This was a Black African woman who had most of her antenatal care overseas. She returned to the UK in the third trimester and went to see her GP. And her GP noted that she was significantly hypertensive and recommended immediate review at the hospital. The GP offered to call an ambulance, and the woman declined and said, "No, I'll make my own way there." She was picked up by a friend, and on the way there, she decided that she actually felt well enough and wasn't going to go up to the hospital. Her friend took her home. Her friend went back and looked in on her a couple of hours later, and sadly, in those few hours, she'd had an intracranial hemorrhage and she died from it. Had she understood the importance of going up to the hospital? Had she understood that her life was at risk? Was she worried about the cost? Difficult to know, but it's really important that we ensure that women who aren't engaging with care are directly targeted so we can understand and individualize what their specific and individual problems are. I'll leave this up for you to read through. Complex medical, psychiatric and social needs often require multiple teams, and it's really important that we actually have a holistic approach. So again, it's about making sure our notes are easy to read by the different members of the team, and important not to assume that other caregivers are actually organising the follow-up, but have actually got follow-up organised and safety nets in place. So if they don't attend to the next person on the list, they still have an appointment with ourselves. And of course, the basics. This is a really sad case. This was a woman who came in labour. She was normal. She had high blood pressure on admission to labour, and it was thought that her high blood pressure was due to pain. She was transferred from the low risk to the high risk labour ward area because she had delay in the second stage. She had an assisted vaginal delivery, and as usual, was given symptometrin for the third stage of labour. An hour later, she had markedly elevated blood pressure, a severe headache, became unresponsive, and had an intracranial hemorrhage. What is really sad is that her blood pressure was not taken between the time when she came in labour with raised blood pressure and when the symptometrin was given. Can we remind ourselves that we need to measure blood pressure hourly in women with hypertension, and that if it's raised, don't assume it's due to pain, but repeat it. When we hand over from one area to another, we make sure we give a full history and use SBAR. I'm now going to hand over to my colleagues from HSIB for them to take on the rest of the presentation. Thank you.
Thank you very much, Kate. My name's Louise Page. I'm a consultant obstetrician for 50% of the week, and the other half of the week, I'm the Deputy Clinical Director for the Maternity Investigation Programme at HSIB, the Healthcare Safety Investigation Branch. Since 2018 in England, HSIB have been investigating a certain cohort of maternity investigations. We will investigate babies who reach the RCOG Each Baby Counts criteria. So those are babies who've experienced intrapartum stillbirth, a severe brain injury, or neonatal death following term labour. We also investigate direct or indirect maternal deaths of women who are pregnant or who die within 42 days of the end of a pregnancy. From April 2023, HSIB Maternity Investigation Programme will be transitioning into a new organisation called MNSI, Maternity and Newborn Safety Investigation Special Health Authority. We look forward to continuing the work started at HSIB within MNSI. So for this collaborative piece of work, we identified a cohort of babies to include in this joint review. So we identified those babies whose mothers had experienced hypertensive pregnancy disorders during the same triennia. And then we selected a stratified cohort, if you like, of 40 babies that we assessed in total. And you can see there on the slide how those 40 babies were selected for inclusion. From the review of those 40 babies' care, we've identified a number of themes, the first of which was learning around pre-eclampsia and gestational diabetes. So in this vignette, the woman required but didn't receive screening for gestational diabetes in pregnancy. During the pregnancy, the baby was thought to be on the larger side. And when labour started, she had care in a midwifery-led unit. As Kate just mentioned, her high blood pressure that was recorded during the earlier part of her labour was attributed to pain. As labour progressed, meconium was seen, followed by non-recovering bradycardia, and the baby was born by caesarean birth. They required therapeutic cooling and ultimately developed hypoxic ischemic encephalopathy. Their birth weight was on the 20th centile. So we know that hypertensive disorders of pregnancy and diabetes share links with the metabolic syndrome. And women with risk factors for one will have an increased chance of developing the other. The coexistence of diabetes and preeclampsia may present a challenge because it may affect how we can recognise fetal growth restriction. It can also impact on the accuracy of the intrapartum risk assessment. So the learning identified from review of these cases was that we need to be aware it's not only babies predicted to be small for gestational age who may be at risk of compromise during labour, when a woman's pregnancy is complicated by both hypertension and diabetes. Our next area of learning was around hyponatraemia. So this woman had intermittently raised blood pressure during her pregnancy, with no formal diagnosis made or treatment needed during the pregnancy. In labour, she did experience high blood pressure and protein in the urine. And like many women, her labour was augmented with oxytocin. She received intravenous fluids and had an epidural. Following a forceps birth, the baby required cooling and had a diagnosis, again, of hypoxic ischemic encephalopathy. Retrospectively, it was identified that during the labour, the woman in the previous vignette had a positive fluid balance of almost 3 litres. Her urine output during her 11-hour labour was less than 250 mils. And after the birth, it was established that both mother and baby were hyponatremic. We know that there's an association between excessive fluid intake and hyponatremia. And approximately 25% of women who take in more than 2.5 litres of fluid, either orally or intravenously during labour, will become hyponatremic. We've seen a number of babies where, on review, it's felt that their neonatal seizure may well have been secondary to hyponatremia, and it's an important differential diagnosis for our neonatal colleagues to consider. What we can say from this review and looking at previous reviews from MBRRACE, that fluid management in pre-eclampsia must be a continued focus for us all. HSIB reviews have also really shown the added value of expert placental pathology. These vignettes explain how review of the placenta after a baby was born that met our criteria really did help families and staff to understand about why that particular baby had been affected by intrapartum events. We know that the perinatal pathology service throughout the UK is under huge amounts of pressure. I'd like to take this opportunity to draw everyone's attention to this updated tissue pathway from the Royal College of Pathologists. On the slide are just a few of the conditions that are included in the pragmatic list of indications for placental pathology, which really does try to balance the learning from expert review of placentas with the problems that we know of with capacity within the system. And now to continue with the learning from the those 40 babies reviewed as part of the HSIB cohort, I'm going to hand over to my colleague Nikki Pusey, who's one of the team leaders for HSIB in the South.
Thanks very much, Louise, and to Kate. As Louise said, my name's Nikki Pusey, and I'm a midwife by background, and I lead a team of investigators in the southwest of the country investigating the cases that we've spoken about. I'm going to talk to you about this mum here, this woman. She was having her second baby. She'd had an uneventful pregnancy until about 38 weeks when she attended for an antenatal appointment, and she was found to have raised blood pressure and protein in her urine. And induction of labour was commenced quite quickly with a prostaglandin pessary, and then this was followed by multiple cycles of prostaglandin gel. 4 days after her induction was started, the mother's membranes ruptured, her waters broke, and her labour was augmented with oxytocin. After several hours, a caesarean birth was performed in the first stage of labour for pathological CTG. Her baby was born requiring resuscitation, experienced seizures, and underwent 72 hours of therapeutic cooling. The MRI performed when the baby was about a week old showed that the baby had hypoxic encephalopathy and subdural bleeding. A common feature of the cases that HSIB reviewed for this work was a prolonged induction of labour process. In many cases, the length of induction was not reconsidered as part of a mother's risk factors, and processes to ensure that women received bedside obstetric reviews were not robust, and often these did not occur for several days. So it was only after 2 or 3 cycles of prostaglandin that mothers were reviewed. HSIB noted that the prolonged induction of labour for mothers with hypertension whose babies were already potentially compromised added a further challenge to the intrauterine environment. And I think it's important to note that as well as the physical harms that may come to a baby, the additional stresses for families whose babies are admitted to NICU can't be underestimated, those early bonding experiences and the impact on life going forward for those families. So the report reinforces these recommendations from the Induction of Labour NICE guideline. It indicates where induction is unsuccessful or where multiple cycles of prostaglandin are necessary, that women's risk status, their physical condition, the well-being of their babies should all be incorporated into a plan that is discussed and agreed with the mother about her onward management of care. This second vignette is about a mum having her second baby. She had a history of pre-existing hypertension. Her blood pressure was measured weekly, and at 20 weeks she was given labetalol. This was stopped 3 weeks later when her blood pressure settled back to a normal range. At the end of her pregnancy, around about 40 weeks, her blood pressure again began to rise. No obstetric review was arranged, and an induction of labour for post-maturity was booked for a week later. During that induction process, the baby became bradycardic and a category 1 caesarean birth was undertaken. This baby also required extensive resuscitation and went on to receive 72 hours of therapeutic cooling. The MRI that was performed at 7 days showed changes, again suggestive of hypoxic ischemic encephalopathy. Another feature of these cases that we reviewed was that normalisation of raised blood pressure was common. In this case, in the previous vignette, once the woman's condition had stabilised, she was then considered low risk by her caregivers and assigned to that low risk pathway. The NICE guidance relating to hypertension in pregnancy advises that where risk factors are present, such as raised blood pressure in this case, an offer and discussion for induction of labour at 37 weeks is best practice. In this case, it is likely that if the mother had remained on an obstetric-led pathway, an earlier induction may have taken place, and this may have changed the outcome for the baby. This report emphasises the advice within NICE guidelines for hypertension that where pre-eclampsia exists, birth should be initiated in the next day or so. And for those mothers with gestational hypertension, a plan agreed and discussed with the mother to include both her and her baby's well-being should take place. What we did find was that there was quite a normalisation bias, an expectation bias that normalised blood pressure. In many of the reviews, including those described above, women were found to have a first episode of raised blood pressure when they were admitted in labour. Staff displayed a tendency to normalise this increase as being related to the pain of a mother's contractions. This would sometimes lead to repeated attempts to measure a mother's blood pressure in order to obtain a value in the expected range. Some instances, this led to delays in obtaining obstetric advice. In others, no advice was sought, as once a normal blood pressure value was obtained, the normalisation bias became superimposed on the expectation that all would be well. Similarly, on many occasions, the cuff size used to measure a woman's blood pressure was factored into a clinician's decision-making processes. Where high blood pressure measurements were lower when repeated using a larger cuff, the lower value was used as a baseline upon which their decisions were made. So in conclusion, I think that it's important to say that midwives and obstetricians are both going to continue to see women with gestational hypertension and preeclampsia. And it's important that these professionals recognise and ensure that women receive their correct care in early pregnancy, in labour and throughout. This is why, as Kate described earlier, the new recommendations mean that in early pregnancy, a new national PGD to allow prescribing of aspirin by midwives and pharmacists is implemented, that electronic records are easily shared so providers in different settings have the full picture. And additionally, those women who are unwell need to be reviewed by senior leadership teams. That may mean ensuring that there is access to a team at a regional maternal medicine unit for advice. And finally, we must never forget that where women have comorbidities such as hypertension and diabetes, all healthcare professionals should be aware that it's not only the babies at risk of restricted growth who are compromised. That's the end of our presentation. I'd like to thank Marion and the MBRRACE team for inviting HSIB to collaborate in this presentation. Thank you.